Early in my academic family medicine career, I found myself in a nerve-wracking situation. The Associate Dean for Academic Affairs, an esteemed endocrinologist and one of my bosses, showed up on my schedule as a new patient. Talk about pressure. After I managed to settle down from a sudden bout of imposter syndrome, things went fairly well, and we fell into a pretty typical doctor-patient relationship. Years later, as I reflected on this experience and other times I've cared for colleagues, I realized something. We physicians rarely, if ever, talk about the emotional impact of treating our peers. That's why I'm so excited to have Claire Hutton as our guest today. Claire's groundbreaking research dives into this very topic, exploring the unique challenges and dynamics at play when medical professionals care for one another. There are times in our lives that change the way we see the world. Navigating these challenges can take insight, trusted confidants, or even a coach. Let's explore those moments. In this companion podcast to RX for Success, we will discover ways to learn and write our own success stories together. I'm Dr. Dale Waxman, a physician coach with MD Coaches, and this is Life-Changing Moments. By way of introduction, Claire is a psychologist and a late-stage PhD candidate at Monash University in Melbourne, Australia. She has long focused on doctors' health, having served as the consultant psychologist for the Australian Medical Association Peer Support Service, where she supervises physicians who support their peers. Her insights are not only fascinating, but also vital for all of us in medicine. So let's dive into the conversation with psychologist Claire Hutton. Claire Hutton, welcome to Life-Changing Moments.
Great to be here, Dale. Thanks for inviting me.
Well, as I said in the introduction, we met briefly at the International Conference on Physician Health in Halifax, Nova Scotia, just this past October. And I was fascinated with this topic, and we're going to get more into physicians taking care of physicians and what that's all about and what you learned. But before we get into that, I just want to know for our audience a little bit more about you. I know where you are right now, but can you tell us where you are geographically and what you do there?
Sure. So I live in Melbourne, Australia, down south, and that wasn't home to start with, but it has been home for the last 20, 30 years. And I am a psychologist by training and still alongside being a part-time doctoral student, I mostly teach in psychology. Well, I teach counseling in postgrad courses, which I love, and see some clients, but that's only a small part of my work at the moment. I realized something had to kind of go when I took on the study. And yeah, so I do a few other bits and pieces. One of them probably more enjoyable, interesting bits of psychology work I do is with a humanitarian aid worker training organization who run residential 5-day workshops training humanitarian workers who are heading into conflict zones. And I am the psychological support person because it's a very involved training with lots of scenarios of, bombs and kidnappings and that sort of thing. And it's a fantastic training, but I also, it's a very different kind of work from the everyday kind of counselling and teaching. And then I do some work with the Australian Medical Association in Victoria as well. Well, and it probably kind of is where my interest in my topic today came from. So the AMA run a peer support phone line. So it's similar to, and I believe you have similar kind of doctors' health kind of services, and certainly Canada does, and they're phone lines. But this one is a little bit different because I train the doctors that volunteer on this service, and doctors and medical students can call up, remain anonymous, and talk about both personal and professional crises they might be having. And so it doesn't need to be substance related or mental health related. Often it is, my wife has finally walked out after threatening to do so because I'm never home, that kind of thing. And yeah, so 15 years I've been involved in training and supervising the doctors that answer the calls on that service. And I guess and then read kind of all the call records that the volunteers complete after the calls. And so, yeah, became very interested, I guess, in some of the stresses that doctors face.
Very interesting. So, and that does kind of may lead us more into kind of that peer-peer
Yeah,
relationship on
yeah.
a little bit deeper of a level when physicians become patients of other physicians, which I promise we'll get to in just a moment.
Oh,
But what I wanted to say about that, we might want to talk more about that because that is a recurring theme on this program is the whole concept of peer support and that physicians, I know in the US, we know from research that their preference when they're going through some distressing times, whether that's personal or professional, is to talk with other physicians. It sounds like that's
yeah,
true in
yeah.
Australia as well, and you're training the
I think
physicians to be
so.
good listeners for that. That's
I
great.
think so. And I think it is. It feels like it's that almost ideal combination of, as a doctor, I can ring the service knowing I'm going to speak to a doctor, but I can also remain anonymous. And so it's set up with very clear kind of legislation that where in Australia, if you, as a doctor, you become aware that another doctor is perhaps not well enough to be perhaps treating other patients, this obligation to actually report them. But this service is set up so that you get no information from the doctor. So the doctor knows you actually can't take that any further. You can provide them with whatever, and you can certainly strongly advise them that they perhaps should be seeking some help. But at the end of the day, there is no information to be able to report them, which, yeah, I think is it's a starting point, and often that's now doctors knowing they can start that conversation with somebody about
Yeah,
what I might need to do about this without the fear of repercussions.
I think that is. The starting point is a good concept
Yeah,
because there is a lot of alienation and loneliness for a lot of physicians, as we know.
yeah,
Well,
yeah.
let's get into this going a little bit further because you did a presentation that I listened to, which and I was fascinated by, which was a study about physicians and in your terminology, GPs, which in our terminology would be family physicians in this country, GPs who take care of other physicians. So my first question is, tell me how you got interested in that.
Well, so the decision to do a PhD, I guess, was, to be quite frank, was because I love teaching. And in Australia, at a university level, you're not required to have a PhD, to be a basic kind of lecturer. But of course, the bar keeps getting higher. And so I could see a point at which that may change. And I really love teaching counseling. So I kind of thought this would probably be a good thing to do. And then choosing an area, then I fell back on that AMA work that I mentioned that I have been so interested and so involved in working with the doctors who volunteer on that service. Even the fact that it's volunteer, Dale, like and I hear about, the orthopedic surgeon who, they're on shift all day, but, in between surgeries, they're popping out to kind of return calls. Like it's just so awesome that they believe this kind of peer support is so important. And then I started looking into that. And I think I had originally thought that the doctors as patients would be the area that I would go down. But in fact, I mean, while there's not a huge amount of research, I guess you were kind of hinting at what I found very little of was the side of the treating doctor when their patient is also a doctor. So I kind of made a shift about a year into the PhD of focusing more on that treating doctor side of what's actually happening in those consultations and particularly how the treating doctor feels, I think, about when they know that their patient is another doctor and what they might then do differently.
We'll get back to our interview in just a moment, but first, I'd like to share a message from Navigate. After spending years in the financial sector, Navigate has met lots of clients with all kinds of student loan issues. They were confused, they were overwhelmed by the doublespeak and the overly complex forms, and especially the deliberately misleading statements from loan servicer representatives. Navigate recognized the chaos in the student loan industry and immediately brought clarity and real solutions. If you'd like to flip the script on student debt, visit www.flipthescript.loan/MD-coaches to schedule a call with Navigate. They'll tailor a plan specifically for your unique situation and work with you until the loan is paid off. What do you have to lose besides the stress of student loan debt?
Hi, I'm Rhonda Crow, founder and CEO for MD Coaches. Here on RX for Success, we interview a lot of great medical professionals on how they grew their careers, how they overcame challenges, and how they handle day-to-day work. I really hope you're getting a lot of great information. But if you're looking for an answer to a specific problem, management or administration challenge, or if you're feeling just a bit burnt out, like maybe you chose the wrong career, well, then there's a faster way to get the help you need. No, it's not counseling, it's coaching. RX for Success is produced by MD Coaches, a team of physicians who have been where you are. I know you're used to going it alone, but you don't have to. Get the support you need today. Visit us at mymdcoaches.com to schedule your complimentary consultation. Again, that's mymdcoaches.com, because you're not in this alone.
We'll get back to our interview in just a moment, but right now I want to tell you a little bit about Physician Outlook. If you haven't discovered this remarkable magazine, please do so very soon. It was created by physicians for physicians to showcase the intersection between clinical and non-clinical interests, whether it's writing, painting, cooking, politics, and dozens of other topics. Physician Outlook gives a physician perspective. It's available online and in print. It's really unique among physician lifestyle magazines. And like the Prescription for Success podcast, Physician Outlook amplifies the voice of any physician who has something to say. It also engages patients who still believe in physician-led, team-based care. And Prescription for Success listeners can get 3 months free when you enter our promo code RX for Success and select the monthly option at checkout. That's a really great deal on this stunning publication.
Was there any particular story or experience that you had that sort of made this really an interesting area for you to look into?
Because that first year I was, I guess, a bit unclear about which area I would go in, I did a study which I haven't yet done anything further with, which was looking at the core records that the volunteers on this peer support service would fill out after every call. And there was a section at the end which was, what was this experience like for you? Do you need any support yourself in taking this call? And so, and with their permission, did some analysis of all of their kind of debriefing notes, really. And they have the option to call me if they needed to, but most of the time the doctors don't. And the themes there were so interesting. And a couple of ones particularly were that the frustration, I mean, of course, they're taught to listen and not give advice, which is very hard when you've been trained as a doctor. But nevertheless, they would say, I would try to do that. But also when I did give advice, it often wasn't followed. And there's sort of frustration that you're talking to a colleague and they're another doctor, but you've got this quite different hat on and they're not necessarily responding in the way that, patients might respond. They would say that the callers didn't always engage with them in the way that they found it difficult when the kind of collegial relationship they might have expected because, hey, we're both doctors, didn't necessarily happen or didn't happen very easily, which I thought was really interesting that even though they know they're speaking to doctors in distress, that at some level, that's why they're calling, they still felt I felt that they felt sort of disappointed that I'm here serving a colleague and I'm not feeling this kind of connection. And of course, that wasn't all the time. I mean, the fact that they noted it meant that was unusual. But those two elements made me really curious about what's happening here. That it's so hard when they have finally got to maybe near the end of the call and they're saying, so I really do think you need to notify your medical indemnity person or your whatever. And their response they're getting is, yeah, great, I'll think about that, but not any really clear sense that this person. So, yeah, that was probably an area that made me start to think about what then happens when, it's actually a clearer, in a sense, clearer doctor patient consultation, as in you've got your doctor hat on, but your patient is another doctor? And are the dynamics different? And
Yeah.
what impact does that have?
Very interesting. So you went into the study. Was it qualitative, quantitative, or a little bit of both?
The original study that I just mentioned then,
The study with the GPs and taking care of other
yeah. So
physicians.
this is qualitative, the one that I spoke about in Halifax. So I certainly wanted it to be qualitative. I felt that, well, I don't think I quite realized how much that would impact. So it really, when I looked back, the longer the interview went on, the more, I guess this is probably really typical, but more insights, and that often the GPs, it was quite late in the interview when they'd start to go, well, I've never really thought about that, and yeah, and I felt, I mean, I was probably a really annoying interviewer, to be honest, Dale, because the counseling side of me, I didn't let people get away with very much. I would really, want to know. One example, sometimes they would say that they would feel embarrassed if they only realized that their patient was a doctor after the doctor had left the consultation. So this idea of not actually disclosing that you're a doctor when you're the patient is really a thing. It's not uncommon, it would seem, and I was not predicting that. And yet, so my interviewee would say to me, and that's quite embarrassing, then when you realize that you've been speaking to a doctor, and then I would say, but why are you embarrassed? Like, the patient's chosen to not tell you that they are a doctor. I'm puzzled about why you would then feel. And then they would say, of course, well, how did I explain things? Maybe I didn't explain things in the right way, or maybe I left things out, and they're suddenly reviewing their consultation in this whole other light if they only discover later that their patient was a doctor. So anyway,
Yeah.
yes, I listened back, and sometimes a bit cringy at myself, because I realized how much I pushed them, because I was so curious about what was happening for the treating doctor.
Yeah. Well, let me back up for just a moment. So that
Yeah.
you started out by identifying GPs who and you said, I'm interested in learning about how it is to take care of other physicians. What was the initial? Yeah. Go ahead.
What they find enjoyable and what they find challenging when their patient is another doctor, and if they're aware of things they might do differently, and if so, for what reasons, and what impact they think that might have on the care that they give.
Yeah. Well, like all qualitative researchers, of course, there's going to be more curiosity that shows up when you hear the responses. And
Absolutely.
I'm sure, yeah. So that makes sense that you would have a lot more questions. Well, what were some of the key findings in your study? What were the themes that emerged?
So I think a really strong one was that this kind of collegiality and respect that is part of that dynamic, because I know my patient's another doctor, how that then impacts on, well, the areas where things like the questions, the history taking, I guess, and that perhaps this is an example of things that only people kind of confessed, in quotes, further into the interview, when they realized that perhaps I don't ask the questions around maybe mental health or substance use, that I would routinely ask other patients, that there is something that happens that they somehow get left out. Obviously, if the patient's presenting for those reasons, that's different. But when it's a more general, I'm not quite sure what's going on here, kind of consultation, and fear of offending them was one of the reasons why that my doctor patient might really not want to be asked these kinds of questions. More testing was certainly something that a number of them would say, you really don't want to miss something when your patient's another doctor. And almost always they would follow that. Well, I mean, you don't want to miss something with any patient, of course, but it does feel like it's worse when it's a doctor patient, and something about, the kind of, well, we move in the same circles, even if they're not a direct colleague, they will know people I know, and that will feel worse if I were to miss something. So certainly over testing was again, not everyone, of course, but a fair proportion, and both quite senior GPs and younger ones. Another one was just feeling very apprehensive. I guess it's linked to the fear of making mistakes, but I think that kind of anxiety was something that surprised me somewhat. That feeling, imposter syndrome was just mentioned over and over again, Dale. It was, and again, not just because I had a wide range of ages and experienced GPs, and the older ones seem to talk about it as much as the younger ones. That do they think I know what I'm doing? Do they, this whole kind of conversation going on in the treating doctor's head while they're actually in the consultation about how is this doctor patient thinking of me, and I need to present as competent. And I think as an outsider, they'll, you kind of have the sense that, of course, doctors have a wide range of, levels of confidence and like any other profession, but it still was quite a surprise to hear such a level of self-doubt and concern that I need to come across well. And maybe the most surprising part of that was that when I started to hear this, and I love that I chose grounded theory. I didn't know a lot about grounded theory when I first started doing the study, but the ability to then change your interview questions and add, and, based on the data that's already coming out. So then I started to ask more specific questions about this. And one of the questions I then added, like very early on, was, so if there's some anxiety about having a patient who's a doctor, is that different if that doctor patient is also a GP or a specialty different to your own? And the majority felt more anxiety when the patient was another GP, which really surprised me, because I just had this idea that when it's the cardiologist of 40 years experience, but they would say, no, the cardiologist usually knows that they know an awful lot about this very specific area and not very much at all about lots of other things. And they tend to be able to adopt the role of a patient, as I know it, much more easily. Which was really surprising, that having another GP across from you, that sort of self-doubt, I guess partly because they will know what I'm supposed to be doing here, and they will know if I'm not following the processes or if I leave things out. And also maybe because I'm more likely to know people they know. If we're actually the same specialty, then if I get it wrong here, or they just don't like how I work, then maybe that's going to have more kind of, will reverberate in a different way if we're actually part of the same specialty. But that was really interesting.
Wow. It's very interesting what those findings. And by the way, I'm, as a family physician who took care of other physicians, I identify with everything that you said. So that would be true here in the US as well. I was wondering though, it certainly, for me personally, you said something about senior GPs, not a whole lot different than the juniors. And I know for me, it got easier when I had a longer term relationship with a physician. And, over the years, I just forgot that they were and they were just another patient. Even though I knew they were a physician, they might have been one of my partners even, but I just I lost that anxiety part. I don't know if you heard anything like that.
I didn't, and I would have expected to. And maybe that's a good point. And I probably didn't specifically ask when you referred to that doctor patient, how long had you been seeing them? Because it seemed to be such a consistent sort of message that absolutely makes sense that it would be less uppermost in your mind the longer that you've worked with a doctor patient. But it really was such a pattern that the younger doctors would say things like, oh, I imagine this gets better as you get more experience. And then, of course, when I did interview a couple of them, 40 years experience, to hear them say similar things. So it didn't really stand out that, if I was seeing them for a long time. Yeah.
Are there any stories that you heard that really stood out for you in addition to what you've already mentioned? Any particular,
There were a couple of the very experienced GPs who, kind of what I was alluding to before about the longer I kind of sat with them, it really seemed like they were thinking very hard about, reflecting on a bit, as you said, about interactions they'd had. And well, actually, it was the topic of the corridor consultation. I think that's a term that you might use in the States as well.
Mm-hmm.
Where,
Hallway.
Clearly we all know they're a bad idea, but what these GPs would say, but it's your colleague in the office next door who pops in for you to write a repeat script. And so one of them would say, now I'm thinking about it, like it seems such an easy thing to do, or you really can't imagine saying no. And yet, if this was a non-doctor patient, the very least I would, take their blood pressure and check a couple of things with them. And I don't do that. And I worry, I think partly because they might be offended if I said, now you are keeping track of X, Y, and Z yourself. But there's this sort of assumption that, so they really were kind of sitting there in the interview kind of going, wow, that's not great, is it? Now I think about it, the things that I might be missing, almost to the point that I was then feeling bad that I've kind of got them reflecting on. Well, another example of the older GP was talking about not asking about alcohol use. And she was kind of saying, I guess I'm assuming that, they're a doctor like me and they're functioning well and successful and they couldn't have an alcohol problem, could they? And they would be saying to me, and I know that's ridiculous, Claire, because I know the research and I know lots of doctors have significant substance use issues, but at the time, they're like me. That what they were kind of saying. I'm seeing them as a fellow doctor who therefore couldn't be having problems like this. And similar to the blood pressure example, both of those I really felt like I might have to go away and think a bit more about this because I'm probably leaving things out that maybe actually aren't doing my patient doctors any favors, that I'm not asking these questions. So yeah, that kind of struck me. The other thing I think was a couple of younger doctors who really, a couple of just only recently fellowed, so a year or two out, would be talking about how they really appreciated the chance to talk about this because no one talks about this, Claire. No one talks in medical training about this. And so that was really interesting. And similarly, a couple of times when I presented on this, it's the really young doctors and medical students even have come up afterwards and kind of wanted to talk about it. So a bit like maybe your response, it's kind of like, wow, we haven't really thought about this, but this is kind of important that we're thinking about what we might not, we want to look after our fellow doctors and there's these kind of things that get in the way.
Yeah. No, I think as I'm listening to you, you're saying I kind of felt bad about what unfolded for some of these interviewees. Yes. On the other hand, they are now checking themselves about the quality of the work that they do. And so, I know that the research isn't supposed to, have necessarily the outcome on the interviewees, but it looks like it might have, and that's maybe a good thing. So it makes me wonder, if you had to summarize, and I want to ask two questions. One is, what are some of the implications of your work for the GPs, family physicians, or just physicians who see other physicians? What are some of the things that we ought to be thinking about? And then I also want to ask, and I'll just prepare you for this one now, is the other side of that, if you have any, what should physicians who are going to see a physician, what might they carry in there with them to prepare themselves to make sure they're getting good care?
Yeah.
So let's start with the first question, which is, what are the implications from your work for physicians or caring for other physicians?
The kind of metaphor I had come up with was this elephant in the room idea that it seemed like for a lot of GPs it was not. Well, there were a number of things that weren't openly discussed. And most of the time they were aware that their patient was a doctor, but I kind of had a question about, is there a way that you would sort of acknowledge that at the beginning of the consultation? We're both in the same profession and, so let me just let you know how I kind of run with this. And if you'd rather, and a lot of them didn't have that kind of spiel at the beginning. It felt like we just didn't really talk about this. And I think I felt like that was one of the things that if there was a more clear kind of have that, very brief, but have that conversation, not a conversation about how we both trained at X, Y, because that's actually potentially a problematic conversation, finding all the points we have in common, but more just, I will probably just run this as I would with any patient and let me know if I'm taking too long explaining something. So I shouldn't, language, Dale, I probably haven't mentioned that yet. And I felt that is a really tricky one, about how much detail, if you both share somewhat the same medical language, it felt like a lot of the GPs felt like they wanted to kind of, not cut corners is the wrong term, but abbreviate things. What we both know what we're talking about. And yet another line I heard a lot was that doctors are unlikely to tell you if they don't understand what you've just said. So the doctor-patient is going to find that difficult. And so if you do use a lot of the more medical terms, they may actually go away with a lesser understanding than a regular patient would have. So I think the language issue is really, so I say that it's tricky because it seems clear at one level, that keep it really simple and maybe preface things with, I'm sure you know this, but, those kind of lines, but still basically explain it. But anecdotally, I speak to quite a few doctors, this happens when, of course, when you're doing a PhD, you become obsessed and you just have these conversations with anyone you meet.
With
My own
everybody.
GP I was talking to recently, and she said, "Oh, I find it really offensive when my treating doctor talks to me, talks about heartbeats rather than, dystolic and whatever the other words are." So I thought, wow, so that's the thing, is that some doctor patients actually will find that. So, but I still feel like, on balance, erring on the side of keeping it simple seems really important, that so they don't go away perhaps being not entirely clear, but not feeling like they might come across as a bit dumb if they actually ask you what you meant by those terms. I mean, another good suggestion, I think, certainly not mine originally, but is having, where possible, a conversation before your doctor-patient comes in to kind of just talk about even basic things like, are you okay to wait in the waiting room? Would you rather we work out something else? Making sure they've left enough time for the consultation, as time, of course, is so often an issue, but also maybe making that point that I generally would like to kind of just run with this as I would with any other patient, and setting those boundaries to some degree. And of course, it's shared decision-making, maybe even more so than with a non-doctor patient, but yeah, actually getting some of those issues out perhaps, so that there's a bit more clarity about, I would just like to run this. I mean, there's even the issues, I know every country is a bit different, where doctors can still kind of add their own tests onto a testing form. If the doctor patient goes away and thinks perhaps you've missed a couple of things, they'll just write their own tests on there. And, so kind of saying, if you felt like I've missed something, talk to me about that, rather than just adding extra things.
So let me just summarize what I've heard so far.
Sure.
So one is just to acknowledge the elephant in the room, that there is.
Yes.
So what I heard, if I heard you right, one of the things you were saying earlier was there is this commonly anxiety, discomfort, imposter syndrome, and one of the ways to maybe remedy that somewhat is just acknowledge. Here's who we are, and I'm just acknowledging you're a colleague, you're a physician, and then negotiate what that relationship's going to look like. I prefer to treat you like I treat every other patient. I'm going to speak in simple language, and if you want something different than that, you can let me know that. But I'm going to treat you the way I treat everybody else, or whatever. Set up the rules for the relationship early on is one of the takeaways that you got.
Absolutely. I think the surprising issue of some doctors, so even of my interviewees, 28, but 7 of them acknowledge that there have been times when they have gone to see a doctor and not told the doctor that they were a doctor. And so when I've asked about that, the standard line seems to be, I did want to be treated like any other patient.
Right.
So that seems to be what most doctors would like.
And I'm curious sorry to interrupt, I'm curious, what do you think? And this might get us a little off track, but what do you think that's about?
It seems that and clearly this is when a doctor's out of town going to see someone else, because mostly they probably would have an ongoing relationship, certainly with a primary care physician. It felt like they definitely have some ideas that things will happen differently. If I go in and they know I'm a doctor from the start, they will happen differently, and that is not what I want. And I know, so it's so curious going, if you know that, then yes, there must be clearly some awareness that, they might order too many tests, or they might not explain things. A couple of my interviewees suggested that maybe part of it is they don't want to be caught out not understanding things. So if I've already told you, or I haven't told you at all that I'm a doctor, then you will explain things as you would to any other patient, and then I won't have to kind of expose my knowledge gaps or something. I mean, no one actually uses those words, but I wonder a little bit. But I still feel like that's the lesser issue. I do feel like it's the doctor patient who chooses not to disclose is part of that same culture, and just aware that it's quite possible that you will do things differently with me once you know I'm a doctor. So if I can just not share that with you. And of course, through all these interviews, exactly as you sort of started this interview with, Dale, is that all these treating doctors have been patients themselves too. And so they inevitably talked about their own experiences as being patients. Like, it's really just those two sides of a coin. And I guess the ones who had really clearly made decisions that they wanted to work in a particular way were often because they weren't so happy with the treatment they had got at times as a patient and wanted to do something differently.
Second question is, what are the implications of the work that all this careful work you did in this wonderful qualitative study for physicians who are going to be seeing physicians So now we're the patients. What are the implications for us? And being somebody who's now more on that side than the
Yeah.
previous, what do I need to know as I'm going to physicians? Well,
One of the lines I liked was about the importance of describing your symptoms rather than your pre-diagnosis that you've already made, and helps kind of both parties stay in their lane, was the expression that was used. And that made a lot of sense, that it's probably harder. I mean, of course, there are very confident treating doctors who would have no issue with saying, I don't think you're on the right track here. This is what I think's going on. But it feels like that if your doctor patient's already said to you, I'm pretty sure this is what something is, it almost can't not influence how your thinking goes then. And whereas if you actually describe the symptoms in the way, again, that a regular patient might, just even that role reversal kind of stuff that happens, I think that maybe you would find it easier to stay a patient. And that doesn't mean at some point you might say, well, I have been wondering if it's X, Y, or Z, but keeping that till later in the consultation, trying to just describe symptoms so that your treating doctors allowed to do their thing and follow the processes that I guess you're taught in terms of how you kind of work through things. I mean, I guess the basic ones, again, it depends on how the medical systems vary, but that allowing your particularly GP to be the one that's ordering the imaging and the testing and following up in the same way, and not skipping those steps, not doing your own referrals, so that somebody's got this full picture of what's happening rather than you following some things up differently. One of the things with the, I guess, psychology background, and maybe particularly with my work with the peer support service, is recognizing how hard it is for some doctors to have an ongoing relationship with a GP, primary care physician, if there's no pressing kind of medical issue at the moment. That, I'll develop that relationship when I need to. And yet, if the first time you're talking about your problematic drinking is with somebody that you've never met, clearly that's a much harder conversation. So it's a kind of the importance of having that, or established relationship before you might need to be talking about more difficult topics. And that's something, of course, that just doesn't apply to, in Australia anyway, any non-doctor, because we don't have that choice. I mean, we have to see the GP. We don't have to have a really close relationship necessarily, but we don't get to skip that step of the system. We always have to be starting with a GP. So you're much more likely to have had more innocuous, easier conversations before you might present with something more hard to talk about. So it'd be good if the system. And I totally appreciate, of course, that doctors are mostly incredibly busy people, and so if you're able to skip a few steps, etc., that can work at some level. But it feels like there really is a cost there when you don't have a good relationship with a primary care physician. Yeah.
Well, as a primary care physician and one of my colleagues said, in family medicine, our specialty is relationships. So that's a very important piece for me. And I think when I did take care of other physicians, I have to acknowledge that I also felt that anxiety. I did not acknowledge the elephant in the room. I just kind of proceeded ahead and took care of people. But as I said, over the years, it just became very comfortable, like it did with any other patient. There's still challenges and difficulties and all that, but I sort of forgot that there was this colleague in the room, and I still ask the same questions that I would of any person.
Yeah.
So what I'm just to kind of, if I had to wrap up and summarize what you're saying is, take the conversation that's in your mind and put it out there in some simple way. You don't have to dwell on it, but just to acknowledge, hey, we're both physicians here. Let's talk a little bit about how that's going to look and what you're comfortable with and what I'm comfortable with, so that we can proceed ahead. I have to say, that some of the things that you said about the anxiety that GPs have in taking care of other physicians, I know that you didn't do the study to find out what the quality of the care was, but you have to admit that if people are afraid to ask about substance abuse and things like that, that's not going to be as high a quality. If they're doing more testing, that's probably also not going to be of as high quality.
Yeah.
And so whatever one can do to reduce that distress, and it may take a few visits to do that, to then drop into they're a patient like any other patient, is what I'm hearing you say.
Exactly. And I think you're right. That's part of the maybe benefit of having that initial conversation at whatever level, but about acknowledging that we are, in the same profession. And because you've had to put some words to, I guess, what's in your head, that probably helps. But I think you're totally right. I think that, again, when I talk to people outside the profession, non-doctors, and I think absolutely there's this assumption that, of course, doctors would just get the best care. And in lots of ways they do. And in lots of ways they jump the queues and all those things, as they perhaps should in some ways. But these aspects is really surprising to people, that in fact stuff might get missed because of these dynamics. And as I said earlier, my initial questions, and I deliberately said them in different orders. So what do you find enjoyable and what do you find challenging? And so for the next interview, I'd always flip it around, just so it never felt like I was, looking for the challenges rather than I got very little about what was enjoyable. And that maybe something about my sample, absolutely. You're asking people to put their hand up to come and talk about this stuff. And sometimes it was sort of almost felt like cliches about it's rewarding to treat your colleagues, and they'd kind of say that and then go, but now let me tell you about what's really hard about it. And so I thought, like, that just on that alone, it would be, you really want doctors to want to do this. And I'm sure there are lots that do out there, but if whatever can start to kind of shift things a little bit, so that the anxiety really at least is not there, or they're aware of it, and have some praise in their mind to kind of reassure themselves that on the whole these are just like any other patients. But the worthwhileness is absolutely there, that the importance of actually being there for other doctors. And of course the other interesting issue, which is probably very different, is the professional very different in the States, the professional courtesy, kind of what you charge doctors. That was another question that I did not have as a question, and then it came up almost every interview. So we have the Medicare system here, the universal health insurance scheme. So, and generally a doctor will not charge another doctor. So they will get that basic amount back from the government and they won't charge anything extra. And they're making a lot less out of, so the better you get at it, and perhaps the more doctor patients you see, the less income you're making. And most of them were very apologetic.
And you're not happy about it. You're not enjoying it.
Well, I know. And they were often slightly embarrassed or awkward about mentioning it. And yet it felt very real. It felt like that's maybe a medical cultural thing that needs to be looked at, because if one of the outcomes is that you are less willing to see doctor patients, then that's not a good thing.
That's not a good thing. Yeah.
But it's a very strong tradition here.
Yeah. Claire, I think you've done quite a service to open this up for people to learn something about, it's a window into what's going on in that doctor-doctor relationship, and when there's the doctor-patient. And I dare say, just like we said earlier, the process of the qualitative research allowed people that you interviewed to, like, boy, I've never talked to anybody about this before. I feel so much better. And I think that all by itself is something also for us to take away from this, is what are some ways that we might, as a medical culture, invite conversation about what this is like. I really appreciate the research. I was captivated when I heard it at the conference, and even more so in talking with you about it now. What do you see as next steps for this area of research, either for yourself or for others? Where do you see things going?
So from a kind of more practical perspective, I guess the Royal College of Australian General Practice has asked me, so they're doing a series of doctors' health papers in next year in the Australian Journal of General Practice, and they've asked me to write kind of a practical, a bit similar to what we've done, but what does this mean? What kind of guidelines would you give? I mean, and there are guidelines out there, but I think often the ones I've read have not really reflected this anxiety kind of element. So that's So I'm writing that at the moment. I mean, I would have been interested, and still am, in actually looking at other specialties, because it may well be some of these aspects are particularly strong in general practitioners, and to actually kind of look at what it's like if you are an orthopedic surgeon or a cardiologist treating another doctor. Do the same dynamics happen? But my PhD supervisors have let me know that that's going beyond what a PhD can. Maybe that's postdoctoral work, because I do feel like there's part of me that says, how much can we generalize based on GPs? But on the other hand, I think the response is similar to what you've said yourself, is that it does ring a lot of bells for people. So it probably is going to be that it's not terribly different, that there is a medical culture, medical socialization thing. And I guess that's probably a little bit what I'm looking at the moment, as well as trying to understand that better about what happens in that socialization process. Even the idea of not criticizing other doctors, it didn't come up so much because I wasn't really looking at it, but it felt like even that doctors, the stories I hear, I guess, is that people would just change a doctor rather than actually let them know that they weren't so happy about what had happened. I mean, obviously, other patients might do that too, but a doctor patient even more so, because there is something about, in that respect and collegiality kind of area that makes it harder to say, I think you may have missed something there. Would you mind going back and adding that test or whatever it is? I just won't come back and see you next time. So I'm interested. It's a much bigger picture. I realize it would be many aspects to medical culture, but it feels like there's something there in the training that is worth looking at further. Yeah.
Yeah. There's a lifetime of research ahead for the people that are interested in this, including yourself. Well, yeah. Blair, thank you so much for taking some time out of your schedule to be a guest on Life Changing Moments. This is a fascinating area, and I know that our listeners will enjoy learning more about that. And what I will do is I'll include your email in our show notes if people have other questions that they want to follow up, if that's okay with you. But I really appreciate this. So thank you so much for being with us today.
Our pleasure. Thanks so much for the opportunity.
Thank you for tuning in to Life Changing Moments. If you enjoyed this episode, please be sure to rate us 5 stars and leave a review. Doing so helps our podcast reach more listeners. Have something to share? We'd love to hear your thoughts. Visit the MD Coaches community on Facebook groups. This dynamic virtual space is a place to continue discussion about life-changing moments and perhaps share some life-changing moments of your own. Join the conversation today.